folks, let's begin. We have three speakers this morning. I'm going to introduce them with their full biography because it's in your program. Following the three talks, we will have a discussion, open discussion from the floor. So be thinking about the questions you'd like to address to the panel. We'll adjourn at 12:30. And what about lunch? Everybody?
Yeah, lunch starts at then.
Then we'll have lunch. Our first speaker, Dr. Alexandra Nolen.
Congresswoman Lee trained you well on clapping. Good morning. Welcome to all of you. I think there's a on the line. And no, I am not the famed architect wife of Sir Michael, although her name is Lexi also. But I did have the pleasure of working on the WHO Commission on Social Determinants of Health. Just to reinforce the idea, as important as that work was, it owes a tremendous debt of gratitude to the prior work of Dr. Syme and many of his colleagues. And I be remiss in recognize how important it is to this field in setting some of the early research, drawing attention to these issues is. And I will say that I do agree with him that the amount of discussion on issues of social determinants of health, even though we have recognized inequity and social determinants' role in creating inequities in health and society for over 100 years, hundreds of years, depending on the research you look at, it is somewhat inspirational to see the direction of conversations as they are emerging recently. I believe that issues of inequity and either implicit or explicit recognition of the contribution of social determinants of health are now a focus of most of the social sector organizations at the international level and are quickly filtering in at the national level in many, many countries. Sir Michael challenged us to put fairness at the center of policy. This is, for some of us, it feels like a struggle right now. Some of us are concerned about the direction that many of our public policies are going in terms of their contribution towards inequities rather than towards equity. But I will also say that when I began working in this field 20 years ago in the United States, that we couldn't really have a conversation publicly about health equity. It was not something that had filtered its way into the mainstream discussions in health, in politics. And I went overseas for several years to work. And when I came back, it was suddenly a mainstream conversation. And that is watershed. It was a tremendous difference being away a few years, and the speed at which these issues were taken up, I think, is heartening and should make us all optimistic that Congresswoman Lee is correct, that this is a fight worth fighting, and it is an issue that we can make a difference in. And this is a really critical time in our country's progress to really try to help make the right arguments. I would contend that health equity should not be posed as a partisan issue. It often is interpreted that way, but the reality is that equity is in everyone's interest. It is not a racial issue. It is not just a class issue. We know about the social gradient now, right? This is an issue that affects all of us. There is also a temptation to sometimes just crunch the numbers among scientists, and this is something that I want to talk about a little bit today, without sufficient attention to context, without sufficient attention to what is it behind the data, behind the information that we are really supposed to be concerned about in the way that it relates to how we have structured our society. Son, do you have my slides ready?
I do.
Great. It is really a reflection of social justice in society, health inequities are. And to that end, we need to be attentive to how they are produced and what impact they have. So both the effect and what's contributing to their causes, right? And that really requires a strong attention to context. So we have two tasks that I would pose, that I would like to say are perhaps themes of this workshop for the week, and that you might usefully think about throughout the week's presentations. One is, how do we get messages out in ways that are broadly understood, not as special interest issues, but as broad societal issues, not even as a healthcare or even a health issue, but as really our health inequities are demonstrations of how we are creating our society, and we should understand them in their full sense. We should understand not just the relationship between social determinants and their impact on health, but also what this means about transportation, what this means about education in our society. What does this mean about how we value our children? What does it mean about how we honor and protect women's health? These are health issues at their core, right? Yes. So we need to think about how we message these issues. And I have a friend who, I won't mention his name, that he works in Washington, and he constantly is reminding me of the need to be careful about language, and he's very strident, and he says, you have to use the language of injustice, and you have to use the language of inequity. And in many contexts, I think he's absolutely right. I also happen to be from Texas, and I know the challenge of needing to adjust your language in different ways for different kinds of audiences without losing the importance of the values that underpin the idea, right? So this is part of that messaging challenge. And for those of you from red states, this is something that we have to continue to work on, because, as we've said, this is an issue. I mean, it's so interesting to me that when we look across political constituencies, many of the people who fall at the bottom of health inequities are people who are often voting against their own interests. What does this mean? What does this mean? I think this is the kind of question that we need a little more information on, in terms of how do we frame issues so that people really understand what it is that we're trying to achieve, right? The second, so getting the message out is one, right? The second major theme, I think, of the week is, we've seen data on inequities, disparities, on all kinds of diseases in all kinds of populations. We see the gradient in almost any situation that we look at. The question is, how do we make the change? How do we create the implementation processes that are going to get us towards a society where, when we look at the health outcomes, we see a more just society? So I challenge you, as people present during the week, to think about these two issues in all of the presentations. And I know that many of the people will be talking about it explicitly. And I would say, look for those implicit conversations too. Those are opportunities for greater expansion of the conversation. Okay, great. So we'll just talk about a few issues. I just wanted to bring up a couple of issues of concepts and definitions, talk a little about why context matters, how does attending to context and values affect research, and how does this lens affect strategies for change. And I'm going to go quickly because we have a lot to do this morning to make up some time, don't we? This morning, Sir Michael cited one of his UK colleagues, Margaret Whitehead, in his definition of health equity, which is differences in health that are avoidable and unchosen. And that's a very widely used definition, but there are many definitions of health inequity. Let me offer you another one from one of our leaders in the United States, Barbara Starfield, who was a very prominent leader in primary prevention and was the founder of the International Society for Equity in Health. Her definition was a world without systematic differences in health status across socially, demographically, or geographically defined populations or population subgroups. There are lots of other definitions. There are definitions that take into account issues of agency, who's responsible for dealing with the issue. There are definitions that are more broadly focused on specifying not just health status, but different kinds of areas. But what's important to recognize is that all of these definitions, once you get to implementation, they really speak to the underlying conditions. They're not just about healthcare. They're not just about the inequalities themselves at an end state. They are really about what are the conditions happening. And that really has to do with the social justice factor and the values that are implicit in understanding when you have a health inequity. So just as an example, these are some of the health equity dimensions that could be captured. Health status, as Dr. Starfield mentioned. But in addition to health outcomes, also discussing harms and risks. Sorry, I'm getting some feedback. Health systems factors, right? So access to care. Also socioeconomic determinants of health. And there's a wide range of determinants, ranging from behavioral issues through neighborhood conditions, all the way up to the ways that we construct our economic and political structures in the United States. There are political and civil factors that may be important to consider in understanding whether an inequity is emerging out of some driving forces. And then there's also looking at the social and economic consequences of illness, which can also be a factor related to inequities. For instance, in 2000, I believe it was 2009 in the United States, over half of personal bankruptcies were related to healthcare costs. Have you guys heard that statistic before? Yeah, it's impressive. It's impressive. One major catastrophic illness was causing half of the personal bankruptcies in the United States, right? It gives you a sense of how fragile we are, not only when we don't have an effective, inclusive healthcare system, but when we also don't have a broader safety net and an economic structure that is able to protect people from those consequences. So what I would contend is that a technocratic approach to addressing inequalities in health that is not based on a social justice foundation likely will not improve health equity in substantial or sustainable ways. Context matters, values matters, both to research methods and to interventions. And research should use data, context, and values iteratively, meaning in a constant feedback process where they are speaking to each other, to be most effective in actually addressing inequities, to making the change that we have to see to be able to say that we're making progress. Okay, so I put this up here just as a demonstration. What do you know? What does this slide tell you? We're very fond of putting up lots of slides with data about inequalities between groups. What can you get out of this slide? Anybody? Sorry? Group B is twice as high. And? We need the context, don't we? We need to know a little bit more about what we're talking about. And I would contend that if we look at a slide like this, we begin to feel a little more comfortable. Did your anxiety level just go down? This is a slide of prevalence of obesity among children according to family income, right? So now we have lots of pieces of information. We're looking at obesity. That's our topic. It's kids. And they are stratified according to their family's income. Did we gain some context here? Maybe. Probably. There's a lot that we carry around in our own kind of inherent knowledge of our communities and our societies that tells us context about these different factors, right? We know what it means to have differences in family income. In the United States particularly because our differences are huge in family income, right? In other countries, the differences in family income may not be as huge. So I would say that in some cases, we carry a lot of that context information implicitly. with us when we look at this kind of data. But this is 3 other different ways to look at diabetes, specifically in this case in Texas. And I think one thing that's important here as students of health equity is to continue to recognize that when we look at these kinds of differences, when we look at racial differences or we look at educational status or age groups, those are equity stratifiers, right? Those give us information about the social position of groups in society. So for instance, if we take race ethnicity, we know that in the United States, who is generally the more privileged racial group? Whites. We bring that local context, that local knowledge with us, right? And yet, if we talk about interventions, are we going to intervene based on race? Are we going to try to change race? No. It's an indicator of what's happening in society, right? It is a proxy, in some ways, for privilege. So keep that in mind when you look at these slides, as you will see constantly during the week, that when you're looking at inequalities in health, that the stratifier isn't necessarily the basis for intervention. Intervention requires additional context, right? It's a different sort of context. It's more about what is happening that's creating these inequalities in privilege. Okay. Now, the other point that I think is really important to make, and which was the purpose of the Commission on Social Determinants of Health, was really to highlight that healthcare is a relatively small piece of what creates inequities in society. And you'll see different numbers attributed to different categories, and sometimes this kind of graph is broken up into different categories. But the consistent message is that healthcare is a piece, but what we really need to do is what? Is really look beyond healthcare to all those other sectors and all those other policy decisions and all those other cultural factors that are feeding into processes that drive inequities. Okay, so let's talk for a second about levels of action in intervention. I mean, we think we've made a little progress with the Affordable Care Act. I have my own bone to pick with some of the decisions that were made, but I'm sure all of us do. But if we try to go beyond that and we think, what does it mean if we're trying to talk about intervention in a much broader way? Let's look at some of the ways that inequities are produced and some of the places where interventions could be incorporated to address them. Okay? So if we start up at number 1, social stratification, we see the effect of social position, people stratified by race and class in society, right? Now this is every society in the world. Every society in the world does this to some extent. How much they do it is a different question though, right? That's driven by other prior decisions and histories. And what that social stratification does is it presents differential exposure. We also know that when there are specific exposures, we can have an impact on the outcome by looking at vulnerability. Specific exposures in a context of social stratification will create differential vulnerabilities, okay, which will result in disease and injury that, again, is unequally distributed in a society. Then when we talk about preventing unequal consequences, that third level of intervention, we can see another opportunity to affect those differential consequences. That creates the social consequences of ill health, that can affect social consequences in ill health, which creates further social stratification, and the process begins again. So there are really 4 opportunities, according to this kind of a model, where you can see chances to intervene to affect health inequities. One is very much upstream as we say, which is related to influencing social stratification. How much social stratification do we think is okay? Right? It's kind of a political decision that a society makes. Then there is the opportunity to decrease exposures, to decrease vulnerability, and to prevent unequal consequences, both through healthcare, for instance, but also through, anybody think of another way to prevent unequal consequences that we've talked about just a couple of minutes ago? Half of American bankruptcies, personal bankruptcies, are created by health problems within families. That's another opportunity, right? If we had a program that tried to address that kind of unequal impact on families due to ill health, economic impact, not just the health impact, the economic impact, that would be another opportunity to intervene that would also help reduce stratification of income. Is that making sense so far? All right, I see some nods, that's a good sign. Okay, so if we think about a couple of the levels, interesting. Where should I be pointing this copy? Can you take it forward for me, Winston?
Hold on, there's some issue with this laptop.
So if we think about 3 levels of research and intervention strategies, we might group them into disease-based strategies, which is generally where healthcare professionals have traditionally been most comfortable. Strategies focused around social determinants and different sectors in society, say for instance transportation or education or any ideas? Transportation, education, housing, land use. Thank you. And then third, something that's a much deeper kind of shift in the way that we structure society, which is about root causes. It is about the social stratification itself. It's about those hard questions of how much economic inequality is acceptable, what should our taxation system look like, how much redistribution should we be doing, right? These are the kinds of questions that really get people's juices going, right? These are the most difficult kinds of interventions, and that we need to make much more progress in figuring out how to effectively message the issue that this is everybody's interest. It's everybody's interest. I will also say that disease-based interventions, and believe me, this is not to knock healthcare professionals or to dissuade you from doing lots of nursing or physicianing or physician assistanting or any other healthcare intervention. But disease-based approaches in terms of affecting health inequities in a sustainable way over the long term, preventing the harms that occur when a disease occurs or an injury occurs, can be least efficient, may not be very effective. Research often has the problem that it can be redundant. There's a tremendous amount of research out there, and it often ignores multiple causal factors in intervention approaches. We really need to understand and strengthen our understanding of when and why such research is useful. We need to be much more precise about how we understand the value of health care interventions. I will also say that I think that there are a lot of quiet reasons why we tend to focus on disease-based interventions that have to do with the economic interests in the way that our healthcare system is structured in the United States. that's a topic for another day, so we'll go with it. These were some observations made by Paula Braveman, who actually was one of the architects of, the U.S. had its own national commission. Do you remember when Sir Michael mentioned that Brazil had developed its own commission on social determinants? Do you guys know that the U.S. had its own commission? Does anybody, who knew that? I'm curious. How many of you knew that the U.S. had its own commission? It was called the Robert Wood Johnson Commission for a Healthier America. Notice the change in language? But it was a really important commission in a lot of ways that's had a lot of influence in doing things like changing and driving how Healthy People 2020, for instance, was developed. Healthy People 2020, if you compare that, does everybody know what Healthy People 2020 is? Okay, lots of nods there, good. Okay, if you look at Healthy People 2020 compared to Healthy People 2010, you see this explosion of richness around the conversation of social determinants of health, policy options for interventions at local, state, and national levels, all kinds of conversations that are incorporated into Healthy People 2020 that we never saw in Healthy People 2010. And that commission and a lot of the other work that's been done around issues of equity and social determinants of health in the United States in the last 10 years is part of the reason for that shift. So I do think that we are making some progress in some areas. Okay, so if we're not supposed to study disease-based interventions, what are we supposed to be studying? Well, Paula Braveman says that we should be doing a lot more work on human rights approaches that push the focus onto root causes of social advantage and disadvantage rather than behaviors. That material and psychosocial dimensions of social advantage and disadvantage, which coexist and interact, need much more attention. That we need more research on time dimension, the duration, and the life cycle of how health disparities emerge, and look at different levels of analysis. So there's plenty of work for the research, right? There's plenty of work left to do. We need research to be focused in the right places, but because the research will drive the conversation that will drive the action. Whoever has control over the research questions has an enormous amount of power over the direction of our actions in the next 10, 20, 30 years. And this is a long project. Don't any of you ever worry that you'll be out of work because we've solved the problem if you go into this work. It's one of the joys. You can give it your full and know that you will always have more to do. Okay. So WHO has its own priority research areas that they've articulated, including a focus on intervention research, implementation research, systems research, root cause research, and multi-level, multi-system research. Now, there is not one of these areas where a deep knowledge of the social justice issues at stake, the values implicit in choices about how you do the research and how you interpret the research, and the impact is not really critical. There is one other thing that I want to make a point on, which is that there is actually a social justice-based argument for which level of interventions, whether you're looking at root causes or social determinants or minimizing the consequences such as through healthcare, how they should fit into our priority system. First of all, I will say that if we agree that we have an injustice, if we can get consensus in the community that something is not right with the way that a process is driving inequities, we have an obligation to correct the injustice. Right? Not just the consequence of the injustice, but to correct the injustice. Whether it's driven by racism, or classism. First of all, we have a responsibility to correct the injustice. Second, we have a responsibility to reduce the harm that it causes. And third, we have a responsibility to minimize the consequence. I would argue that we should look at the interventions in those priority orders. If we can't correct the injustice, that is our first obligation. If we can't get consensus, then we should directly reduce the harm when we see an inequity. And when we can't do that, we should minimize the consequence. Okay. I would just like to conclude by saying, you can give this workshop 100 times in every city in the United States every single year and not reach everybody that we need to reach with the central core work of this workshop, which is to really help people understand how inequities are tied throughout society to every decision that we make as a community at every level. We need to be giving these kinds of workshops to educators, to land use planners, to city planners, to master neighborhood developers. Where do we see the most poverty happening in the United States right now? Suburbs. Very few people are paying attention to how suburbs are created. They need to be brought into this conversation. We need to have incentives structured for them to be addressing the kinds of issues that affect people at the neighborhood level. Bankers, architects, restaurants, childcare providers. Every single one of these groups could benefit from the kind of discussions that we will be having in this workshop this week. And I hope you enjoyed it as much as I